Welcome, everybody. We are here today with a very special guest, Dr. Carolyn Moyers. She is a certified OBGYN, is the founder and CEO of Sky Women's Health. We've asked her to come on and give us some insight. She specializes in helping women when they're perimenopause, menopause, postmenopause, all of those things that we men, we just don't always know how to respond to that, how to support our partners when they're struggling with that. So first of all, I just want to say, Dr. Moyers, we are honored to have you here and thank you for spending this time with us.
Sure. Thanks for having me. I'm excited that men are interested in learning more. I always get thrilled whenever a man comes to the gynecologist because they're there to support their partner and educate themselves so that they can be a better healthcare advocate and a better partner at home.
Yeah, absolutely. And I think our men, they struggle a lot with erectile dysfunction. A lot of the men who work with us at Tim Medical, they've gone through a radical prostatectomy, pelvic injury, but a lot of them are just dealing with organic erectile dysfunction and they've turned to a vacuum erection device. A lot of the men are in relationships. A lot of the men are in relationships with women who are needing to go to see their gynecologist. And I think we sort of branch off and the men deal with their stuff and the ladies deal with their stuff. And what we're trying to do is bring those together and say, if you're in a partnership, if you're in a relationship, how can you join in that and make each other stronger? If I may, the first question I have is if you can go through what women experience, and I know that there's no absolute, everybody experiences these same things, but first of all, on the hormonal front, what's happening, perimenopause, menopause, what's going on there for them?
Menopause is defined as being 12 months without a cycle, and the average age is 51 and a half in the United States, so 51 to 52. Menopause are the years leading up to that final menstrual period that can last 7 to 10 years. So this is not a short phase of life. We see divorce rates go up in menopause. Women don't feel themselves because of the erratic hormonal shifts that we're seeing in perimenopause. We have these beautiful graphs of what our hormones do throughout the monthly cycle. And in perimenopause, it looks more like the Dow Jones chart. There is nothing organized about it. You can't tell what's going on all over the place. And this affects every system in the woman's body. So we see a decline in estrogen and progesterone, which lends to vaginal dryness and thinning tissue and discomfort with sex. We see testosterone and progesterone decline, affecting energy and mood and libido, and the hot flashes and the night sweats that are disturbing the sleep that leads to low desire just for generally most activities in life. It really has nothing to do with their partner because they don't have the desire to do much of anything that they used to want to do because they're simply exhausted and don't feel like themselves. And when women don't feel like themselves, they don't show up in the same way sexually because they're not feeling confident.
And that hormonal change that's occurring, it's not an abrupt, like you wake up one day and you're like, what has happened? It's more of a gradual, and you don't necessarily notice it's happening until you get a year down the road and you're like, I don't feel like I did before. I don't have the energy. I don't have the libido. It's a little bit adversely affected, right?
Well, so what's interesting is that no particular individual, there's not a set series of symptoms that are going to occur for each individual. Perimenopause looks different in every individual. While some people may have more irregular cycles, it's not that their cycles are just going to go away. They may start bleeding profusely or having more frequent cycles. Some people may have ringing in their ears. Some people may have more depression and overwhelm, anxiety. So the symptoms can look very different. There's even musculoskeletal symptoms that can occur. So throughout the body, it affects all because we have estrogen receptors throughout the body. And so these changes are erratic and the symptoms are somewhat vague because they affect so many different systems in the bodies that oftentimes patients don't put the pieces of the puzzle together because even palpitations, their heart, this feeling that their heart is racing can be due to those erratic estrogen changes. And so while in menopause, when we're done with that, when our ovaries have stopped producing estrogen and progesterone, those hormone levels just stay low and flat. And perimenopause, they're all over the place. And so oftentimes patients are running to this specialist and that specialist. They may see the endocrinologist and the cardiologist just trying to put the pieces of the puzzle together. They may see their PCP and well-intending get their lab work done and they say everything is normal. And the patient is like, They feel kind
It's
of
not.
dumbfounded, like, but I don't feel normal. And this is when they start feeling dismissed and looking further. And eventually, a girlfriend or somebody puts the piece of the puzzle together, or their spouse will do the research and say, hey, I found this menopause specialist. You need to go see them. So, a couple of resources for men would be menopause.org, because you can look up by your state or by your zip code and find a menopause certified provider. So, Menopause Society certified provider. You're looking for that MSCP at the end of their name. You don't want them just to be a member of the Menopause Society, but to have that certification, because that shows a commitment to their education so that they're continuing to stay up on the latest information when it comes to perimenopause and menopause.
Brief interruption to the interview where we draw your attention to the For Her tab on the timmedical.com website. And if you click on that, you can see a variety of products that we have available for ladies, whether it's a lubricant, a moisturizer, different massagers, but check that out. Click on them, see what they have to offer, and see if they might be of interest to you. And always want to remind you that any product that you order from timmedical.com that exceeds $75, the shipping is free. So just scroll down through there, get an idea of what we're offering on the site, and also why we're offering it. But check it out, timmedical.com, click on the For Her tab. Two ladies who are friends about the same age, both experiencing symptoms, they're talking, having a conversation, and one might say, well, this is what's happening for me, and the other one might say, well, I'm not having that at all, but I'm having this. So the symptoms aren't necessarily exactly the same. And a partner
Exactly.
might say, well, my friend's wife, she's having hot flashes. I would expect you to have hot flashes, and his partner might not have them. So it's not as just like this happens when you're 51, this happens when you're 52, that kind of thing. So
Right. And it can get even more confusing for patients who've had an endometrial ablation, or they have a Mirena IUD, or they've had a hysterectomy. Like, they may not be having a regular period. So they have a little extra layer of complexity or confusion about, well, I don't know, when am I going to be menopausal? So what often starts happening is they're not going to have the erratic bleeding, but they might have more PMS type symptoms. They may start having hot flashes and night sweats. They may notice more dryness and discomfort with sex.
I hear you saying, and tell me if I'm wrong about this, but the hormonal shift is sort of the driver for most of the things that you've talked about. Is that
Yes.
accurate? Okay.
Yes.
So that's key. Just understanding that. Um, talk to me about some of the emotions you see among ladies who come in who are dealing with some of these things that we've just talked about. How does it affect them psychologically, emotionally when they're going through that process?
Yeah. So, we see a lot more mood swings, irritability, brain fog, anxiety, difficulty focusing, low mood, depression. People who have a history of depression or postpartum depression, we definitely have a risk of that resurfacing. Many patients just say they just have this change in identity. Like, I don't feel like myself. That's one of the most common symptoms we hear, is I just don't feel like myself anymore. And it spills over into self-image, right? When we're not feeling ourselves, women don't want to show up naked. So something to really remember as a male partner. Like, it's not you, it's how she's feeling right now. But the mood is a big piece, and we want to make sure that we don't ignore that, because mental health is health. And we know that hormone therapy in the perimenopausal period can be as effective as antidepressants. Now, we don't see that in postmenopausal, but in perimenopausal, maybe it's because of those severe fluctuations in hormonal therapy and stabilizing them. I'm not sure why that seems to be as effective as SSRIs, but that is what the research shows.
That's big. That's big. So let's talk about that. The treatment with hormone therapy. What does that look like? When should somebody start to pursue that? When is it too soon? When is it too late? I guess not too late, but how would you guide in that direction?
Yeah, so I would say as soon as a woman has persistent symptoms for 3 to 6 months that are not really resolving and don't seem to make sense to her, it's time to get an evaluation, because we start treating in perimenopause. Now, that hasn't been a topic of conversation for most of history. It was always postmenopausal hormone therapy. But to your question, we have to take into account a couple of considerations. In perimenopause, do we have sperm in our life? do we have permanent sterilization on board, right? Because if you're in your late 40s, you may not be planning on a oopsie baby because now we've induced some regular ovulation with proper hormones. So if we have permanent sterilization on board, then we have a little bit more flexibility in terms of what we can do for therapy. Now, our treatment options in perimenopause include birth control pills, which don't affect hot flashes and night sweats quite the same, but for some people, they are effective and can help to carry them into menopause. We can do a progesterone-only birth control and then use our traditional estradiol in a patch or a gel or a pill, so they can use traditional estrogen hormone therapy with a progesterone-only birth control pill or a progesterone-producing IUD to control their cycles and also to provide pregnancy prevention in conjunction with traditional hormone therapy. Now, if we have permanent sterilization on board, let's say spousal vasectomy or the patient's had a tubal, then we don't have to worry about that pregnancy prevention, and we could do more traditional hormone therapy. And some patients tolerate that better, do better, have more symptom relief. So there are plenty of options. Now, if we're postmenopausal and that's not a concern, then that looks like estrogen plus progesterone. If we have a uterus still, we have to use progesterone. If we've had a hysterectomy, and we only have to use estrogen. And the big concern with the Women's Health Initiative back in 2002, when many patients were pulled off of their hormone therapy, was that it causes breast cancer. Now, all of those claims have been debunked. We know that those in the estrogen arm had a significant decline in breast cancer incidents. Those in the estrogen and the progesterone arm had a few additional cases, but not statistically significant. So there wasn't enough of an increase to say this causes this. And that in the Women's Health Initiative, the average age was 63. So not the average person who's going through perimenopause or menopause and starting hormone therapy. Because remember, perimenopause will show up in our late 30s. And most people are going through menopause 45 to 55. It also only looked at one dose, one route, one formulation of estrogen and progesterone. So there are a lot of flaws there in that it's not really looking at our real world experience. And we do not see that same increase in incidence with progesterone, which we typically are using. We're typically using estradiol and a micronized progesterone for our hormone therapy.
Okay. All right. That's much appreciated. And I know that most of the men who just heard you talk there for the last 4 minutes, they're like, what? What? What?
We didn't even get into testosterone. We can replace testosterone in women too, because women produce testosterone as well.
And I think that's a great approach. And that's a great appreciation that I have for that, because it is, if it's overwhelming for me as a partner, I know that it's got to be overwhelming for her, which leads to the next dynamic, which is we as a couple. If I know that hormone, treatment on that front might help, don't know exactly what it looks like, know that it's very safe, and she knows the same thing, how do we approach that? How do I, as a partner, say, well, you know what you need? Hormone therapy.
Yeah. Yeah.
Because that's not going to go over well. But
Yeah. She definitely doesn't need you to mansplain it to her.
I was reading this article and no. So how does it, and you've dealt with couples, you've worked with couples, and
Yeah.
probably there are quite a few where she's coming by herself and he's just like, you go do your thing. That's on you. Other couples, he's probably like, I want to come with you. I'll sit in the car, but I support you. How do you encourage, couples to just sort of move into that space where they're starting to say, what does treatment look like for this? And it's a we thing, not a you thing, me thing.
Yeah. So some of my patients who are in the most distress when they come in oftentimes do bring a partner or a support person with them to just so they have that extra set of ears to hear all the things and to go through the options. And then I always send them to my podcast, because if you've got a question about it, we've probably done a podcast on that specific topic. And I've just laid, 15 topics on you, and they can go and kind of piece it out. But having them come to that first appointment is oftentimes helpful to help them sort through their options. And then as they start feeling better, all of a sudden you see this woman become more confident, and she's coming by herself, and she just has more of her vibrancy back. But I think having those open conversations are so incredibly important, and understanding that 90% of it has nothing to do with the partner. Like, it is not you. It is that she does not feel at home and body.
And we say the same to the men who use our vacuum erection devices. It's such an emotional thing for them. And in the same way, their partner's like, what am I not doing right? Why can he not function, the way he used to? And particularly for those men who've gone through a prostate removal surgery or even partial prostate removal, it has nothing to do with her. It really is. But we always encourage our men, don't fight this battle by yourself. Incorporate this into your passion, your lovemaking, and make this a part of who you are as a couple. And in the same way we're
Right.
saying to the men, do the same thing, to the wives or the girlfriend. Bring him in. He wants to be a part of this, and let's handle this as a couple.
Yeah, I think that's so important, because we're talking more about the systemic aspects of the hormone therapy shifts that we see. But the very real thing is that the majority of women in later years stop having sex because it doesn't feel good, because it hurts. And our brain is smart and avoids things that are painful. And so we have to make sure that we address the changes that happen to the vulva and the vagina as we age, because the tissue starts to thin. The urethra becomes more prominent. Changes are going on that make it uncomfortable. And if we don't address that, if we don't give back estrogen to the vagina, every vagina loves estrogen. If we don't solve that issue, then she's not going to want any type of penetrative sex, right? And so I think that it's important that we address that and we show some grace and we wait for the treatment to work, because it takes about 8 to 12 weeks of consistent use. And then some patients come back and say, okay, it doesn't feel like sandpaper anymore. It doesn't hurt to have sex, but now I want it. Right? So we may have taken care of the hot flashes and the night sweats, and we're finally getting some solid sleep. And we've addressed the vaginal dryness or the genitourinary syndrome of menopause, and they can finally have pain-free sex. Sometimes we even need an estrogen testosterone cream to the opening of the vagina, because that area is called the vestibule, and that vestibule sometimes can be thin and inflamed. And so we'll do a compounded estrogen testosterone cream to that opening. And that a lot of times will do away with the pain at entry. But some patients then come in and say, okay, but now I still don't have that desire, that drive, those spontaneous thoughts of sex. And I would like to be the one to initiate it. So know that your partners are thinking about this, and they are bothered by the fact that their desire is less than it once was.
And we've talked about that. The physical symptoms, painful intercourse and those things. But again, if you can just refresh my thoughts on the lower desire. I mean, everything else could be, as a result of the therapy, functioning as it should, but then the desire has not yet recovered. How does a couple deal with that? What's causing that to happen?
Well, that's the question for all time, right? It's definitely multifaceted. I mean, it's not happening in a silo. And we always say that with sexual health, it's biopsychosocial, right? That biopsychosocial approach. So what's going on with the biology, right? So we address the physical symptoms. The psychology is, how does she feel about the changes? How does she feel about what's going on with her body? How does she feel about the relationship and how the relationship has evolved? And then from a society standpoint, what has she been told about aging, and how does she feel about all of that? And what was she taught about sex? Maybe she's rethinking all of that. So we have to take in that entire perspective, and also understand that the brain loves novelty. And in long-term committed relationships, it's very common that we see this responsive desire and not that spontaneous desire like we often see portrayed in Hollywood and in pornography. That is not reality in a 20, 30-year long relationship. Like been there, done that. We know what that's going to look like, right? So sometimes it's bringing novelty in. Sometimes it's going to sex therapy. Sometimes it's, reading a new book. Like there's a great book by Kelly Casperson, who does a lot of sex med, called You Are Not Broken. And I love it because as a urologist, she sees it from both sides, all genders. And she it's a great, easy read that goes over all those aspects of sex. And I had a patient who we addressed her genitourinary symptoms. She read the book and she was like, I'm good. I don't need any medication for sex drive. That book was gold. Like I just had to shift my thoughts about my sex life and everything is better. So I love that because we do have to take a multidisciplinary approach. And, some patients buy the book and never read it. Some people are halfway through it, but she actually read it and it changed her mind about sex. And now that she's not having any pain, she's good to. We do have medications to treat low sexual desire for women, though, which is phenomenal. I'm so glad that I'm living in this age. So we can replace testosterone. And that for hypoactive sexual desire disorder, we replace testosterone in women to a female physiologic range. So our goal is not that she has male levels of testosterone, but that she has a female physiologic level of testosterone. And a lot of times this helps not only with that sex drive, but just the drive in general, right? Because we're replacing this hormone that our bodies and brains so desperately desire. And they'll find that they have more drive for life. They report an improvement in mood and energy and in cognition. So maybe some less brain fog, but it's indicated specifically for that low sexual desire. We do have to monitor levels to make sure we're not getting super therapeutic.
Sure.
And then we also have 2 different medications. Addie is the little pink pill, a nighttime tablet. And then we have Vyleesi, which is an injectable that women can use up to 8 times per month for sexual encounters. Most women are not excited about the on-demand. I got to tell you, though, most women are not excited. At least that's what I see in my practice, and that there's less enthusiasm for an injectable to get in the mood.
It feels contrived, or is it just the injection that they're fearful of?
I think if they have a lack of desire in general, they have a lack of desire to inject themselves to get one. Like the feedback that I get is kind of like, yeah, I'm not doing that. They'd much rather take a nightly pill or do a daily testosterone gel. But the response rate is around 60%. So I typically will tell patients, 3 to 6 months, let's give it a try, consistently use it, and let's see if it works for you.
That makes perfect sense. I think a lot of the men who currently use vacuum erection devices, they do so because the tablets weren't working for them, sildenafil, and that whole class, but they don't want to do the injections for some of the same reasons. It doesn't seem right. It's a little fear-based. So they're like, all right, I'll use the vacuum erection device, and that works for them. So I totally understand that. So I want to kind of close things out. We could talk for a long time. I want to value your time, but I think one of the things I've heard you say is, maybe you didn't say this just how I interpreted it. Don't think about menopause and treatment, hormone therapy, any kind of therapy from this is going to lead to sex kind of thing. Instead, think about this as a partnership. We're in this together. Whatever happens as a result, it would be beautiful if we had this great intimate love life that like we had when we were 36, but it might be different. And just be open to that, be open to the treatment, be open to being honest with each other and just expressive and support each other. I think that's what matters most.
Yeah, absolutely. And just remember that midlife brings a very interesting time where women have been taking care of the household and taking care of kids. And now maybe we've got aging parents and she might be at the height of her career. She might have some medical conditions herself. That all affects desire. So the more you can create intimate moments, the more likely you are to see that desire. Because what women often report to me is that they're not sending that invite, right? They may put the heels on and go to the party reluctantly, but when they do, they're like, this was fun. We should do this more often. But then they never send out the invite, right? And that's what bothers them. So it's not that they don't enjoy themselves, but get creative. It doesn't always have to be penis and vagina sex.
And it could be better than it's ever been.
Yes.
Right? I mean, it's different. You've been together 20 years, 30 years, and it's going to be different. But different
Yes.
doesn't have to be not as good.
Correct. Yes. Yes. Many women report that they're having their best love life in their 60s. But what I want men to know also is that women often more commonly assume that it's their fault. Whether they have the lower desire or the higher desire, we take it on. They think that they need to fix themselves. And I think it's important to not put the blame on the woman. Like, you need to go to the doctor and, this is your fault, right? Because she will assume that herself anyways.
And that accomplishes nothing. And I think the men also do the same thing. What is wrong with me? And some of it is lifestyle choices, and some of it is injury, some of it's surgery. But no matter what it is, they take it upon themselves. And so you've got two people living in silos, isolated, thinking it's my fault, when instead you just come together and say, Well, if we're
Yeah,
going to
let's have
solve this,
conversation.
yeah,
Yeah.
yeah, absolutely. Well, Dr. Moyers, I really appreciate your time, and it's very important to me to draw attention to where our viewers and listeners can find you. I know that you, like I said at the outset, you are the CEO and the founder of Sky Women's Health, based out of Texas. Only folks in Texas can reach you for treatment.
Yeah,
You
so
couldn't tell us.
I can serve patients in Texas and in West Virginia virtually
Okay.
and in person in Texas, obviously. And then I host Sky Women's Health podcast on all major platforms. And I also created a course to teach other providers because the majority of healthcare providers have not been taught menopausal care for the last 20 years. And I do it consistently and have taught some of my friends, and they kind of egged me on to go ahead and create a course. So I've got a menopause master course for anyone who is interested, and you can find that at drcarolynmoyers.com.
And you mentioned earlier that uh, continuing education units are available through that course, right? Did you?
That's right.
So just take a look at that. I'll put all of the links to all of these places you can find Dr. Moyers in the description for this video, and also put it up on the screen for the course, the podcast. I've listened to the podcast, and you're not just sort of making it like a little bit at a time. You're really cranking those things out with such great content. So we
Thanks.
appreciate that. Yeah, that's some great stuff. So we really appreciate your time. Is there anything else you want to leave us with as we say goodbye?
The only other thing I thought of is that there is a fabulous other resource for individuals or couples who are dealing specifically with sexual health issues, and that's ISHWISH, or International Society for the Study of Women's Sexual Health. And I'm a fellow of ISHWISH, but you can also go to ishwish.org, just like menopause.org, and find a provider in your area.
We got a lot of links in our description, and I love it. That means
Yeah, a lot of
you,
resources.
you provide so many great resources. And the other one was the You Are Not Broken. I'll put a link for folks to take a look at that. That's correct. So again, thank you. We're very honored.
Thank you for having me.